So good evening, doctors. I'm Dr. Prachi from Shield Healthcare, and I welcome you all for today's webinar. We are starting Trending Ask Expert series. I'm very happy to announce that we are starting this series under the aegis of Academy of Global Obs and Gynecology. Let us see a short video. And let us see the short video of task series. Thank you. So today's this task series first episode would be moderated by Dr. Niranjan Chavan, sir. I'm very happy and privileged and honored to introduce sir. Sir is a professor and unit chief LTMMC and LTMGH SAN Hospital, joint treasurer-elect FOXI till 2024 and vice president MOGS till 2022. Sir is also Dean of AGOG, and with this, may I request Sir to moderate today's session. Over to you, sir, and thank you very much. Welcome, sir.
Thank you so much, Dr. Prachi from Shield Connect, and it gives me a pleasure to start with the Trending Ask series on the 24th of June 2021. We are in the midst of pandemic of COVID, and we are going to discuss the trending topics which are there thriving in our country and in our region. And for that, we have our esteemed guest of honor and chief guest. I would like to introduce one by one all of them and request them to speak and guide us 2 minutes of their precious time. It's our honor and privilege to have Dr. Hrishikesh Pai sir to be the chief guest today. He is the president-elect FOXI 2022-2023, medical director of Bloom IVF Group. It has got 12 centers spread all over India, and he has been in this profession of infertility and IVF for last 35 years. He is also the administrator of FOXI Manyata Initiative, and presently he is the director of the corporate affairs of the International Federation of Fertility Societies. He has been also conferred with a fellowship of the Royal College of Obstetrics and Gynecologists, and we all know that he has been the past president of ISAR, IAG, MOGS, and also the Secretary General past and the senior vice president and the treasurer chairman of FOXI. So welcome, Dr. Hrishikesh Pai sir. We request you to please be the chief guest today and guide us for this program.
Thank you, Niranjan. It's a great pleasure and privilege to be here today. Some of my friends and seniors, colleagues like Dr. Avinash Subbe, famous Dr. Madhuri Patel, who is our now the incoming Secretary General, just 2 days remaining, I think, for her to become the new Secretary General of FOXI, and the great Shashank Joshi, Komal, our chairman of the FOXI Medical Disorders Committee, all of you are Dr. Prachi, Mr. Prasad, and a lot of the Shield. All of you are there today, and I'm very happy that you have called me to inaugurate this episode. It's my privilege. And, as you know, that we are going through this pandemic, and, Shashank and Dr. Avinash and all of them have been at the forefront of handling this pandemic. And we are very proud of them that they have really effectively handled it in our state of Maharashtra and our city of Mumbai. We are really grateful to them as well. Today we have got beds available where if we have a problem, we can go to the ICU, and that reflects on their leadership. And it's this also underlines the fact that when the state relies on the medical fraternity, our state really relied on our medical fraternity's advice. And this is what we are having today that we are quite relatively stable. Our vaccination drive is going well. And I'm sure that we will get adjusted to this pandemic, and our economic activity will also start, and we will be able to get on with our life again. What we had a great life before the pandemic. Our academic activity presently is only digital based, but slowly, I hope that we come and meet each other in person as well. And, create, because medicine is not only about knowledge, it is also about human interaction. And that is most important through actual meeting each other. So that's very important. And I hope that we'll be able to go back to the old days, maybe in a different format altogether, maybe in a hybrid format. But again, I would say that this period has also thrown up a lot of new possibilities of learning, education, interaction, communication. I just now was, listening to Ambani, Mukesh. He just launched the new Jio, in the annual general body. What fantastic vision is there? With digital networks, and they have come out with a new Google phone that will be, all the people in the country will be able to access Android phone. Imagine, and they're coming out with, it's a tie-up with Google. So Indians are very aggressive and very progressive as well. And I hope that with this digital revolution, we'll be able to reach each and every corner of our country. And I'm very excited. I wish I was 30 years younger so that I could have relived this whole new experience. But maybe other younger people generation will be able to enjoy the fruits of our older generation. Thank you for calling me, and I hope I'm looking forward to a fruitful interaction with all of you. Thank you.
Sir, the way you are so dynamic and enthusiastic and energetic at this age, you are still young at heart and you are still young in your body. So there is no iota of doubt. And we are honored that you have accepted to be the chief guest today. Thank you so much for your pearls of wisdom. And we look forward to your lecture on artificial intelligence in reproductive medicine. Mind you guys, this will be the first time a lecture given by Dr. Rishikesh Pai on artificial intelligence in reproductive medicine. Thank you so much. Now I call upon our guest of honor, the lady who is going to be the first lady of FOGSI to take the post of Secretary General of FOGSI in the next 3 days' time. She is very hardworking, a great academician. She was also the professor at the ESIS hospital. I remember she being working as an associate professor at the JJ group of hospitals, along with Dr. Professor C.N. Purandare, an iconic personality who took FOGSI to higher and great levels to FIGO, where he became the FIGO president. She is also attached to her private clinic and a consultant to the police hospital, Mumbai, St. Elizabeth and Masina Hospital. We are also aware that she is a part of the editorial board of the Jogi Journal, which is a pioneering journal. She has also been the former committee member of FIGO. Madam, thank you for giving your valuable time in spite of your being in a busy schedule today, having your OPD. Please, we request you to please be the guest of honor and guide us today.
Thank you, Dr. Niranjan. Can you hear me? Am I audible?
Yes.
Thank you, Niranjan, for your very warm and generous words. What I deserve, you have put me at a very, very high level. But these are your motivational, speech for me, which I will keep on working. Rishikesh has also told me that Madhuri, we are going to be together. He was my secretary general when I was treasurer, and we had a great time. And we will definitely work. We are working for patients, but we are also going to work for our FOGSI more and more, and we'll take FOGSI to very great heights. So with this respected chief guest, Dr. Rishikesh Pai, President-elect FOGSI, and my very, very dear friend, always he helps in a need and always he guides me. And guest of honor, Dr. Avinash Supe, I happen to know him as an, dean, excellent dean, dynamic dean, of the KJM hospital and the director of the medication department.
माधुरी म्यूट झाले. माधुरी unmute.
Okay, now okay. Okay, could you hear me?
Yeah,
Because-
you're audible now.
Okay, so Rishikesh is my great friend and always helps me whenever we require, anything in Foxy or otherwise also. And Dr. Avinash Supe, I'm very great fan of you because I have heard about you. I was not in KM, but I'm at Wadia Hospital honorary. So I have heard about you. He's an excellent dean and excellent director of the medical education department. Niranjan here is there. He has done so many CMEs, so many webinars. He's all over India, all over internationally known personality, and he is today's moderator for the program where training arts expert series. He is also going to be joint treasurer. He is joint treasurer elect, and he is also going to take the post after 3 days along with me as a secretary general. Then we have among us Dr. Sashant Joshi. He is very well known as an endocrinologist in our gynec obstetric community. So everybody knows him. Yes, doctor, if I have to refer the patient in endocrinology, I have to refer to him. So he's well known in our OBGY, OBGY consultant. So I express my heartfelt gratitude to Dr. Niranjan Chavan for inviting me as a guest of honor. In today's scenario, as Rishikesh has said, it is very important to update ourselves and that what is happening around the world. And Dr. Rishikesh has rightly said that COVID has created so many problems. We have vaccination, we are going to have third wave or not, that of course Dr. Sashant Joshi is going to explain us. So it is what is happening, we will know with this trending, thing. And also, so medical field also requires updateism. So today we have Dr. Shashank Joshi, a great orator who is going to talk on COVID-19 Delta strain and third wave of pandemic. And Dr. Rishikesh Pai he's a captivating, remember, captivating orator. He can hold back all the public all the time when he's talking, and he's going to talk, an infertility specialist who is going to enlighten us on artificial intelligence in reproductive medicine, which are need of the hours. Dr. Niranjan Chavan doing a great job and organizing this series, and I congratulate him for the same and wish him all the best for the future endeavors. Thank you very much.
Thank you, madam, for that wonderful guidance given to us. We are honored that you have taken out such a valuable time. I call upon my next guest of honor, and it's my privilege to have Dr. Avinash Supe, sir. I have been privileged that he has taught me in my MBBS days in 1986, and we all know him as a great surgeon. Sir has been also at the helm of office as a director of medical education and hospitals of the Mumbai Mahanagar Palika. We also know that he was a dean of St. GS Medical College and the Lokmanya Tilak Municipal Medical College. But the most important thing is that he is a great human being, a worker who takes everyone together, a leader who has a passion for his surgery, and presently he is at the COVID Maharashtra Task Board member and doing a wonderful job. And that's what we see the fruits in Mumbai and in the rest of the Maharashtra. Sir, I request you to please give us your pearls of wisdom for today's Trending Ask program.
Sure. Thank you. Thank you, Dr. Niranjan, for the first congratulations for conducting such wonderful program. And thank you for welcoming me at guest of honor for this Academy of Global Academy of Gynecology and Obstetrics. I think one of the most important aspect feel is that you have really planned this trending, which is the need of the hour, very classical update, and was happy to see Dr. Rishikesh Pai, who is now going to be the president-elect, Dr. Madhuri Patel, and you and the whole team. I would like to really congratulate. For two things, you have really selected two very brilliant people for this particular session. Dr. Shashank Joshi is a really brilliant person who has guided whole state of Maharashtra as well as maybe India also about in this COVID wave. He is an academic strength and he has really the wisdom which he has really put it into the heart. I really appreciate. All of us know that we have tackled the second wave, but our end is a thick tell. You know, we are still going through the end of the second wave. And at that stage, we have seen the Delta and Delta plus variants. Already there are in the 9 countries. India has seen now more than 40 patients. And though it is more infectious, it may not be so hazardous. But we have to be worried about it and see that we take care of this third wave if it comes to, and sure, which will probably occur. And if you do vaccination more rapidly, probably we will make that third wave milder. So I think it's a very relevant topic and a relevant person who is going to speak to that. And second, also, I feel the future of surgical branches is artificial intelligence and data and technology. So I think this is rightly, Rishikesh has mixed this, and he's talking on artificial intelligence and research production technology. I feel personally feel this is the one of the futuristic topics. So you have really balanced the current trend with futuristic trend, which is one of the best thing what you've really done. So congratulations to all of you, and all my best wishes. And I'm looking forward to listen to both the lectures. Thank you so much.
So thank you so much for that wonderful inspiration words which you have given to us. And it's an honor that you have been a part of this program. I am really in depth to you, sir, for giving your valuable time. Sir is available presently at Khar Hinduja Healthcare Center, and he has been a wonderful surgeon, a wonderful human being to be there. So with this, we go ahead without much ado to start with our lecture series, and I call upon Dr. Shashank Joshi, sir, who is presently the Maharashtra COVID members post. He is also a consultant and endocrinologist at Leelavati Bhatia Hospital, and sir is also the past president or the past dean of the Indian College of Physicians, president of Indian Academy of Diabetes, past president of Endocrine Society of India and Association of Physicians of India. He is also a Padma Shri. He is the only doctor presently from Mumbai who is having a Padma Shri, and we are honored. And well, what can I say much more? He is a very simple man, and he is going to talk today on a wonderful subject which we are going to talk. And it's really, we are all worried about the Delta variant strain, the third wave pandemic. So without much wasting time, I would like to call all of you, my chief guest, the guest of honors, and my esteemed speakers to please invoke Lord Ganesha and have Saraswati Vandana before we go ahead. We have the lamp lighting and we spread this knowledge, small droplets in the ocean of academics. Thank you so much for all of you to being there with us. And this would have not happened without the expertise of Dr. Komal Chavan, who has guided us all together. Dr. Komal Chavan, thank you for being there with us. And of course, the platform which has been provided on Shield Connect, it is also available on Facebook and also available on YouTube. So we go ahead with the Trending Ask series today, and I have with me none other than our first session speaker, Dr. Shashank Joshi. I hand over the mic to sir, and he is going to speak today on the third wave pandemic. He is going to talk also about the Delta strain variant which we are all worried about. So please go ahead, be ready with your questions, because once we finish the lecture, he is going to answer all your queries and all the doubts which you have in your mind. Welcome, sir.
Namaskar. Thank you so much, Dr. Niranjan Chauhan. And first of all, I must compliment and congratulate you and your full team for getting trending topics. And, though I'm an outlier, my endocrine world is more closely connected with OBGYN. And it is really nice to see my good friend, Dr. Rishikesh Pai, Dr. Avinash Supe sir, and Dr. Madhuri Patel, and of course, Komal and everybody. And, I'm not going to take too much of time, but I'm going to talk extempore. The reason I'm going to talk extempore, Niranjan, is because COVID documents are all live. Niranjan is my friend on Twitter. Every minute there is a new publication on COVID. So the only one thing which we know about the SARS-CoV-2 virus is it is predictably unpredictable. It is predictably unpredictable. The first thing is that when the wave started, how did it originate? That is the first question which trended a lot in the last 2 weeks. Is it a accidental virus which jumped from the wildlife kingdom into the human space, or is there some human touch to it? So let me tell you the truths. Of course, it's very difficult to find out truths in origins of the virus, but we may have data in times to come. The first truth is that this was a wildlife bat virus which jumped the gun into the human Wuhan district of China. And from there, it has spread across all geographies of planet Earth. So this is the first thing. It is most likely an accidental lab spillover, but it's unlikely to be man-made. Probably it was there waiting for it to happen, and there was probably a human accidental spillover. What is missing in one of the key cogs of the pandemic is that we don't have the index case on which a microbial new virus is cloned. The first SARS-CoV-2 came and went. The first MERS came and went, but SARS-CoV-2 is here to stay. The second question is that we had the first wave last year. The first wave was probably the original strain or the Wuhan strain. We don't like to give it geographic names. And that strain was spreading with a R0 of 3.5. So if 10 people in a family were getting the virus, was exposed to one of them, then maybe 3 or 3.5 people got the virus, but not all the 10. And that first wave, started somewhere in March last year and lasted up to September, and it peaked in September. And by the time we were in Diwali and Christmas, that wave had almost gone. We all know that we had experiences from Spanish flu, that you have one wave followed by a second wave, followed by a third wave, and followed by a fourth or a fifth wave. Spanish flu occurred more than 100 years back. And when that Spanish flu virus wave occurred, we know that the second wave was more lethal than the first wave. We all predicted, and every mathematical model which was invoked in the COVID space was wrong. Only thing, the models which worked were the ones which predicted the wave every 2 to 4 weeks. And therefore, what happened then was most people predicted the second wave between 25th of December and 26th of January. But unfortunately or fortunately, there was genome surveillance which was done in United Kingdom. And they were studying 5% of all the people who are getting infected by the COVID virus by the genomes. Now, you know, the COVID virus is like a football with spikes on it, and the spike proteins can get antigenic shift or antigenic drift, which means there could be amino acid sequences on the spike protein which may change, and these are called as mutations. So there were some spike protein mutations, and these spike protein mutations were picked up in September, but discovered by Public Health England in the month of December. And when they were planning to celebrate Christmas, they went for a very tight lockdown. And this was predominantly seen that almost COVID had disappeared from United Kingdom. Suddenly they saw from the county of Kent, a strain which appeared. which now we popularly call as not the UK strain, but the alpha strain. And this strain emerged, and therefore we actually locked in India, Mumbai particularly, that no anybody coming from UK was locked out. Very similarly, genomic surveillance data from South Africa found out that there was probably a South African strain, and that strain now goes by the name Beta. So the alpha came in November from UK, Beta came from South Africa, and at the same time in India, the birth of Delta strain had occurred. But we went for a very tight lockdown around the Christmas time and January time, and we all thought that COVID is gone. And then suddenly in the month of February, we found from districts of Amravati, Akola, Yavatmal that there was an outbreak, and that was preceded by a small mini outbreak in Kerala. And we found something called as a double mutation. And probably now we know in hindsight that this was the so-called Delta strain or the Indian strain, which was 617.1, which is Kappa, 617.2, which is Delta. So Kappa and Delta were born in India at that point of time. Simultaneously, we knew that in Delhi, in Punjab, because there's a lot of mobility and migration and cross migration between Punjab, Haryana and Delhi and United Kingdom. The alpha variant had landed in north of India, and we had the Delta variant, probably homegrown from Vidarbha and Marathwada. And that is where the genesis was there of the second wave. The second wave started very insidiously, but what was very surprising is there was a freak test positivity from Amravati. Amravati reported a test positivity rate of 53, which means if you tested 100 people in Amravati, 53 people were positive. So obviously, if 53 people are positive, we get alert. We think something is happening because normally the R0 is only 3.5. So this was very high. So minute it was red flag, genomic sequences were done, but it almost took a month and a half to get those results. Though the BJ Medical College had picked up the strain and it was clearly identified and clearly spelled out. So clearly we knew that we had some problem which was happening in Amravati, Akola, and in the Vidarbha districts and in Marathwada districts. And this was a very fast spreading strain. So if in a family of 10, all the 10 were getting infected with the COVID virus. So it was very rapidly transmissible. So just like the alpha strain from United Kingdom, this was a rapidly transmitting strain. Fast spreading, fast recovering, but probably low case fatality rate. And like wildfire, it spread across the whole of India. And in April, May, and now in June, the strain was there. We broke all records because it was spreading very fast. The R0 from 3.5 went up to 7. It doubled the R0. And that's why what happened is because it was a very fast spreading strain, more people got affected. And it strained our healthcare infrastructure, whether it was Mumbai, Maharashtra, India. And that was a problem. And that is why we had to go for a semi-lockdown like situation without using the word lockdown in most geographies of India. It spread across India. It didn't spare anyone. And even now, it is very much prevalent. Even now, we are reporting around 40,000 cases per day. Even to yesterday, Maharashtra had 10,000 cases per day. And even now, we are losing around 1,200 to 1,400 people per day. But just 3 weeks back, we were losing around 4,000 people per day. So obviously, this wave hit us very hard in the month of April and May. Fast spreading, fast recovering, low case fatality rate, at least in Mumbai and Maharashtra. However, when we went to New Delhi and Punjab and Haryana, the fatality was almost double. There, the wave was very ferocious and the fatality was higher because probably there was an admixture of alpha and delta strain. So Delta strain predominantly is from the lineage and sublineage 617.1.2 and .3. And predominantly what got classified as Delta was 617.2, which is rapidly transmissible. Virulence is unknown and may have an immune escape. So this is now becoming the most dominant strain across the world, whether it is UK, whether it is USA. This Delta strain has become very popular. And this Delta strain, probably because we know it spreads fast, may be more virulent because it may have a more affinity to the ACE receptors in the lungs. And you know that there is COVID in the nose, there is COVID in the throat, and COVID in the lungs. And nose COVID and throat COVID is what 80% COVID is asymptomatic. But in the symptomatic COVID, people who get nose and throat COVID, they recover and they do very well. If you lose taste and smell, you will recover and do very well. But if the COVID goes in the lungs and it causes desaturation, then you need steroids, you need some immunomodulators, and you need, of course, prone position in oxygen, but you can save lives, but that becomes a little too late. So remember that this Delta variant may have had higher virulence, but data is still not available. Now, as the second wave has been receding, suddenly we are seeing a spring up in the last week of something called as Delta Plus. So what is this Delta Plus? So worldwide, there are 4 strains. The Alpha strain is from UK, rapidly transmissible, probably less virulent. Second is the Beta variant. The Beta variant is from South Africa. South Africa's biggest problem is if you use Covishield, it is not effective. 80% of Covishield doesn't work there. So it has immune escape or vaccine escape. The third strain is that from Brazil called Gamma strain or the P1 strain. And the fourth strain is a Delta strain. Delta strain is predominantly restricted to India. And the Delta Plus is AY1 and AY2. So this Delta Plus or AY1 and AY2 was seen in UK, in Nepal, and now also reported in India. So obviously, a lot of work is happening. The CSIR, the ICMR, and the INSACOG, which is the genomic consortium mapping the genes of the virus, were looking what virus is prevalent in India as now the pandemic is coming down. So as the pandemic is now coming down, the first thing is that if we need to unlock, there are 3 parameters on which we have to unlock. Number 1, for that geography, the test positivity rate has to be below 5% for 2 weeks. And right now also in Maharashtra, there are 7 districts of concern. The first being Ratnagiri, Sindhudurg, and Raigad, which are predominantly the Konkan region, which are districts of concern with test positivity rate above 5%. And they probably have the Delta Plus or AY1 strain. The other districts of concern from Maharashtra are Kolhapur, Sangli, and Satara. They are also districts of concern. A lot of vaccination has happened there, but their test positivity rate is also high. And there have been some cluster spreading events, including a High Court mandated election there. And the 7th district of concern in Maharashtra is Hingoli. So those are the geographic hotspots of Maharashtra right now, is districts of concern. But in these districts, we need to look for these novel strains. You know that in Jalgaon and in Ratnagiri, in Palghar and Mumbai probably the patient was tracked down to Ratnagiri, probably has this AY1. Now this AY1 was, I said, in UK, it was in Nepal and in India. And you know that Konkan is popular for mangoes. So you know that the removal of the mangoes, a lot of people come from Nepal and they pluck the mangoes out. So when they plucked the mangoes out, there was a suggestion which was felt that was it the Nepal strain of the AY1 which came here. Fortunately, the genomic testing of Nepal is done by the same lab, the Institute of Integrated Genomics and Integrative Biology from New Delhi, Dr. Anurag Agrawal's team from CSIR. And they found that that Nepal strain and the strain found in Ratnagiri were different. So this Delta Plus may be less transmissible. There is only mild to moderate disease. The data is scant and may not be as strong as the original Delta. So what happened in the first wave was the original strain, the Wuhan strain. It was fast replaced by the Delta strain. And now across India, we have the Delta strain. All Delta strains are variants of concern. And that so-called Delta Plus, maybe Delta Minus, is AY1, which is now likely to be propagated. Whether it will be more lethal, more dangerous, we don't know, but unlikely. Is it more transmissible? Maybe, but we need more data. What does it tell us? It tells us that the solution for COVID today is COVID-appropriate behavior, COVID-appropriate protocols, and vaccinations. So the first thing is COVID-appropriate behavior. People have got fed up with the mask, but the virus in the mind is as dangerous as virus in the body. We need to double mask because we know the virus is airborne droplet. So if you unmask yourself and have a cup of tea or coffee, you are likely to get the virus. And even a casual contact can spread the Delta or Delta Plus. So the lethality of Delta plus is in the transmission. The transmission for a couple of minutes without mask, if somebody is harboring the virus, is bad and the viral load can be very high. So that is the first thing. The second thing is you need to continue sanitization, though the fomite transmission impact is much less now. And third thing is distance, which is very difficult to follow in places like Mumbai, which are cluttered and clustered. So we need to adhere to strict COVID appropriate behavior. Second thing is COVID appropriate protocols, which means we need to avoid crowds, congregations, and all gatherings, social, religious, political, completely, because they become transmission and spreader and super spreader events. So that is something which is mandatory, which is required. And the third thing which you need to do is there has to be well ventilated rooms, or if there are poorly ventilated spaces, then there has to be circulated air, which can be used by a simple exhaust fan, or can be using not only just a simple exhaust fan, but sometimes beyond an exhaust fan, also a HEPA filter. So remember, having well ventilated spaces, good ventilated spaces, HEPA filters will be the order of the day. So that is COVID appropriate protocols. But we need to restart our economy. So we need to vaccinate our population. And we need to at least have an herd immunity threshold. So we need 60 to 70% of our population vaccinated. So if you really want to unlock a geography, we need test positivity rate less than 5% for 2 weeks. We need non-strict adherence to COVID appropriate behavior and protocols. And we need to 70% vaccinate the population. Any vaccine is okay, but vaccination is mandatory. Because more you will vaccinate, the better will be the herd immunity threshold. We have very good data that you can get vaccination doesn't prevent infection. Even after 1 or 2 vaccines, you will get a breakthrough infection. But data published from Fortis Group, Apollo Group, CMC Vellore clearly has shown that the breakthrough vaccines of infection after 2 vaccines usually tend to have mild disease, very rarely severe disease or death. And that's something which we know much better. And if the Delta plus occurs, it could have immune escape. It may not respond to the antibodies well, and it may actually have the stickiness to the ACE2 receptor. So those are the 3 concerns which are there for Delta plus. So one thing is very clear cut, that we need to vaccinate. We need to vaccinate a large geography. We need to adhere to COVID appropriate protocols, COVID appropriate behavior. And even if a Delta or a Delta plus comes, we probably as healthcare workers also may need a booster, but may not be with the same vaccine which you have taken in the past, maybe with another vaccine. But COVID is still in an evidence-based mode. So we have very scant data. We are still in a research mode. We still have live documents. And therefore, the only thing which we can do is we can continue double masking. We can continue being in less crowds and better ventilated environments. We can take appropriate care and precautions and vaccinate everybody around us. The faster we vaccinate, the faster we will come out of the pandemic. A lot of people ask me, and that would be probably where I will conclude, and I'll be happy to answer as many questions as I can, is when will COVID end? You see, we were in the BC era, before COVID era, and we all dream that we should be in that era. Now we are in the DC era, which is during COVID era, but we are all wanting to see a post-COVID era, PC era. So when will that post-COVID era really start? For that, as I said, at least 70-80% of our population has to be vaccinated. Personally, I feel, at least as far as India is concerned and globe is concerned, April 2022 to July 2022, we will be able to get out of a normal life with or without COVID, without any disruptions. Right now, what has conquered us is uncertainty. We don't know when we'll lock and when we'll unlock. Whether we'll get a third wave, we'll not get a third wave. So the last part of that is, when will the third wave come? So as I said, that if we follow strict adherence to unlocking of TPR less than 5% for 2 weeks persistently, 70% of vaccination, as well as zero tolerance for COVID appropriate behavior and protocol, our third wave will be delayed, and most models predicted between September and November. The better will be the vaccine adherence, the later will the wave come, and the lesser will be the wave. However, unfortunately, even when 40% of the India is still having COVID compared to what was there in April, people think COVID is over People are on the roads, people are unmasking, not following COVID protocols. So the third wave may not even come. This same second wave will get another blip or a second hump. And this second hump might be bigger than the first hump. And that is why across the country, particularly in Mumbai, Delhi, we are worried that particularly if a Delta plus like variant comes in, we may be in trouble because it may escape vaccines. It may be little more lethal to the lungs, and it may be fast transmitting also. So I think it's a cause of concern. We are at healthcare. We are at the forefront, and vaccines are here, but vaccines can escape. If you have taken 2 vaccines, then we need to probably get another vaccine. Do not go by standard tests of antibodies. The classical spike protein antibody IgG, which you get, gives you a false sense of security. I have enough healthcare professionals, including doctors, who have had more than 250 of that IgG spike protein antibody, thinking that they are protected. They have unmasked, and a variant of concern or a mutant has entered them, and they have got COVID, and most of them have survived. So remember, it's a false sense of security. Quantitative measurement of such antibodies may not be sufficient. If at all you really want to measure the antibodies, then you need to do neutralizing antibodies. These neutralizing antibodies, gold standard test is PNRT, which only vaccine manufacturers do, or sometimes we have to do a virus neutralization test, which very few labs in India do. So remember that, do not go with a false sense of security. Even if you have had 2 vaccines, masking is mandatory. Try to live in bubbles. Try to do essential activity. We definitely need to restart our economy, but we need to do all this very slowly. In the next 3 months, if we can sufficiently vaccinate India, Maharashtra, Mumbai, quick and fast, we will be out of the woods. But we'll still need to follow some protocols of less crowding and appropriate behavior. Because if we don't do that, and if we get a variant of concern lurking very quick and fast, we'll be back to square one. So the lessons we learned from between the first and the second wave, we should not replicate between the second and the third wave. Let us hope and pray that this wave, which is predicted to come in September, which many people think might come earlier now, because remember the gap between second and the third wave in UK was only 8 weeks, 2 months. And people feel here it may be only 2 to 4 weeks, the gap between the 2 waves. But now that also may not happen, because already we saw from 6,000 cases in Maharashtra in Sunday have gone up to 10,000. So we should not allow the second wave, as Niranjan said very rightly, the thick tail to go up and it had to have a hump. And Mumbai still has a thick tail. Mumbai has still a little bit of Kappa variant, which is 617.1 apart from Delta. But most of India, the Kappa has been wiped off by Delta. So currently the dominant strain in India is Delta, and some geographies across India, only 40 samples, they have seen a Delta plus strain or AY1. And this is coming through genomic studies. In fact, one of those study groups I'm a part of between the Institute of Genomics in Integrative Biology and Government of Maharashtra. Many such groups, including ICMR, TIFR, many of them are doing genomic sequences, and they will be the variants of concern, variants of interest. But that is an interesting area to understand. As healthcare workers and doctors, what concerns us is the newer variants are still around. They may bypass vaccines, and we still need to depend on the strongest vaccine, which is double masking and being in good aerated environment. So I think I'll stop here, Dr. Niranjan. I'll be more than happy, and I'm grateful to Dr. Supe also for suggesting my name here. And I'll be happy to answer questions, because our whole idea is that as we move in the third wave, we need to save every life, and we need to ensure that there is no severe infection, and that is very likely to happen. The faster we vaccinate, the better where we'll be as far as the third wave is concerned, unless, as I said, another variant of concern comes up. For example, you must have read last week that in Peru there is a Lambda variant, which is a variant of concern. So these will all keep on coming. These all Greek letters will keep on coming. At least the geographies have gone, because the racial and the ethnic and the geographic correlates have been removed. But all these variants of concern, we should not dismiss them. COVID is very much around. We still need to behave responsibly. We still need to tell our patient they need to behave responsibly, and we still need to be cautious and careful. I think a lot of healthcare workers have died, and it's very unfortunate because of COVID. And now our objective is to save and safeguard all of us, and save and safeguard all our citizens of planet Earth. and ensure that we save every life now here on in the COVID era. Thank you.
Thank you, sir, for that exemplary extempore presentation given by you. There are many questions which are being there, but you have rightly explained the history, the geography, and the present of the Delta variant and the future about the second and the third wave. And I want to tell you, more than 2,500 members are logged in right now. They are on Facebook, they are on YouTube, they are on Shield Connect, and they are directly interacting with you. There are many questions, more than 150 of them, but most of them are quite repeated, sir. So I will take one by one. So the concern is now the first question which comes from is Dr. Ranade. He is from Pune, Vidyadhar. Do vaccines used in India, do they provide immunity against Delta? What is your take on that, sir?
So currently they can save lives and severe infections can be reduced, but you may get breakthrough infections. For Delta is concerned, we have a concern that the Covishield may not be as effective, particularly for Delta plus. We know that there is data available from outside of India. But whatever laboratory data on variants of concern was published from Covishield and Covaxin, both of them seem to have some data of protection against variants of concern. So that was very reassuring. But the breakthrough vaccinations for both the vaccines is ongoing right now. And because it is ongoing, we need to understand one thing very clearly, Niranjan, that there is likelihood of breakthrough infections. Only thing is, after two vaccines, the severe disease or death may not occur. But we have also seen exceptions there, including doctors who have passed away. So we need to be very, very careful that, we need to be cautious and careful as healthcare workers. And probably right now vaccines are fully regulated. But if I had a choice, probably I would take an mRNA platform vaccine after taking 2 Covishields or another platform vaccine in a mix and mass trial, or I would enroll myself in a research trial. But right now, if you have natural infection and then you have taken 2 vaccines, your likelihood of protection is much better. If you have had 2 vaccines without natural infection, then your likelihood of protection is there for saving life and severe disease, but may not be there for infection of mild to moderate nature.
Thank you, sir. Sir, right now we are having one more vaccine. This is Dr. Alka Kute from Amravati. What about Sputnik vaccine for Delta plus variant, and about vaccine to be given to pregnant and pediatric group? There are 3 questions being asked by her. Can you take one by one each of them?
So I will take quickly. Sputnik vaccine is 2 shots, excellent efficacy up to 91%. Data on Delta plus or Delta variant is not known, likely to be effective, and has the same adenovectoral platform, but 2 adenovectors, just like the Covishield. So likely to be protective. As far as pregnancy is concerned, my personal opinion is should be given. Okay, Government of India is a little bit on the fence on this, but I feel that, but because we need to generate data, but I think pregnant women and lactating women should take it. But in general, women as a sex are better protected from COVID compared to men, and so are pregnant women. So that's number 1. Number 2. Number 3, children, data on children is emerging. There is no vaccine in India approved for children. Covaxin is undergoing trials. Covishield trials are between 12 to 18 are ongoing, and Zydus Cadila 12 to 18 trials are ongoing. Children by and large below age of 10 have less density of ACE receptors, so they are likely to be protected. They have already been exposed. They have thymus. So, and they also get non-specific protection from BCG, oral polio, and flu shots, as well as MMR or measles vaccine. So there's a lot of non-specific protection for children. But yes, we need pediatric vaccines, and they are not available. Pregnancy, I think Foxy has been pushing very hard to get the pregnancy approval for pregnancy in COVID, and should be done according to me. But we need data to be there. In US, it's allowed. I don't think there's any challenge with that. So I hope it answers all the 3 questions.
Dr. Rishikesh Pai, you wanted to ask a question to Dr. Shashank, sir.
First of all, Shashank and the team has done a fabulous job in Maharashtra. What I wanted to say was, it was an observation that if we have to drive the economy, means we should permanently have a, what is known as control lifting of the, the lockdown, in the sense that why don't we just, first of all, vaccinate the people who drive the economy. So frontline workers, we have already vaccinated, those who are in the shopkeepers, those who are actually day to day going to offices, and then we should identify one person from every household who will be allowed to go and take the, let's say, buy fixed stuff from the shop. So only those people should be first vaccinated. So targeted vaccination should be done so that the economy starts running, and the remaining people should be protected in their houses. So in that way, we'll be able to bring back the livelihood without jeopardizing and without exposing our main population to, and maybe you can use some kind of artificial intelligence to, because this is being used in China. So we can use that to target and selectively target and give vaccination. So because, as Dr. Shashank was saying, it is going to, maybe the wave will come. So this way, what we do is we don't lift the lockdown. Also, we can run offices only for 3 days in a week rather than, so compulsory running, because we run the offices from our house throughout the 7 days. Why can't we permanently lock down and run them 3 days a week? So all these legislation or changes should be done by the committee. This has been my, because I have not been able to access them. So this is my request to them from this platform.
So Rishikesh, you're very right. All this is controlled directly from the central government. And we have a team of some of the best vaccine experts on earth who have successfully, mainly their pediatric group, who have successfully ran pediatric vaccination programs of polio and smallpox, and they have eradicated it. Unfortunately, in COVID, two problems occurred. Number one, the vaccine was not available in free supply. And number two, that the strategy is very dependent on the supply chain of the vaccines. What you are saying is very true. It's called as targeted vaccination or ring fencing. That if people, what we want to do is try to shrink the number of susceptible people by vaccinating only those people who are likely to be exposed. So for example, say taxi drivers, rickshaw drivers, people who are traveling by public transport like trains, buses, they should be given a priority. Unfortunately, because it is a transmissible disease which is airborne, probability of herd immunity threshold should be there for everybody now. So that phase we have actually passed that phase, if you ask me, Rishikesh. And I agree with you that if we have a choice, we should go in that graded way. First, we started vaccinating above 60 because they were vulnerable. Then 45 to 60. Then with comorbidities. Even for children, when we have vaccines available, first we should vaccinate comorbidities. And you are very right. People who are going to go in the forefront, because we feel that a third wave is likely to come for people between 20 and 40. And in whom will it hit? In the people who are going out for their livelihood. So those are the people who we should, prioritize and vaccinate. So unfortunately, that prioritization of vaccine and distribution is left partly to the state, but is predominantly decided by the center. The other problem is in rural India, there's a lot of vaccine hesitancy even today. So even among healthcare workers and frontline workers, vaccination is not 100%. In fact, in Maharashtra, only 41% of doctors have been vaccinated. So this is another problem which you're facing. But Rishikesh, you're very right. Even we don't have many access to much of the vaccination program and policies, but we do send our suggestions. Niranjan, you are muted. Niranjan, you are muted.
Yes, sir. Sir, this is regarding a question from Dr. Patil from Karad. Why is it that even after being vaccinated, there is an immunity which has been created? Still a doctor who is working gets COVID infection. Obviously, it is, as you have said, it is not of severe nature. But why is it that after getting vaccinated, still there are antibodies, but still the person gets COVID infection?
So as I said, Dr. Niranjan and Madam, that the challenge is that we are not able to generate through the vaccines good quality neutralizing antibodies. and that is called as immune escape. And that is what has happened. And that is why we may be able to prevent severe disease. So, the first yardstick of the vaccine is 100% death reduction. Second is 100% severe disease. But efficacy is measured by symptomatic infection and asymptomatic infection. So a lot of people still get breakthrough of mild or asymptomatic infection. That has been a very tough target. So very right, because we are not able to mount a reasonable neutralizing and a T cell response. And the virus has become smarter. That is why all these variants, they have something called as immune escape, because they make the body, they outsmart us.
Absolutely wonderfully explained, sir.
Can I ask question? Can I ask question?
Yeah, Madhuri. Yeah.
Yes, sir. Dr. Shashank, see, when we started a vaccination drive, that time we were the doctor who took, first dose and the second dose after 4 weeks.
Correct.
Now there is a 84 days gap. So who is going to be more benefited, we or the other people who are taking after 84 days?
Can I tell you one thing?
Yes.
Nobody knows the answer to this. But what is the published data? After 4 weeks, if you take 2 vaccine shots, if the old variant was there was 65% protection. Okay. And if the old variant was there, and if you took 2 shots at 3 months or 4 months interval, then there was a good 80% protection. So 65 versus 80%. But with the Delta variant, UK rechanged the policy. They said now give 2 doses within 2 months. So now people who have got 2 vaccines, when it comes to the Delta variant or Delta plus variant, you are likely to be better protected.
Sure.
Because with a single dose, it's only 30%.
And one more question, sir. Thank you very much. One more question. That, I did not have COVID, but my husband had a COVID in month of July, 2020. And so then he also took a second dose after 5 weeks. Then what happened when we did the antibody titer? For me, the antibodies are within the range of 125 something, and he had 2,500. So this was his third dose, if you take it that way. So are they protected more now?
I don't know. So we can't answer that question. Reinfection is also known. So don't go by those levels of antibodies. You go to Breach Candy with Aruna Pujari and get a virus neutralization test done.
Okay.
That is in percentage. More than 20% means the antibody can block if there is an exposure to the virus.
Okay.
In all probability, your husband is definitely having will be able to mount an immune response even if there is exposure. And in all probability, even you will be able to mount it. But there will be a differential because, he has technically got 3 doses.
Right.
Obviously, and he'll also have T cell immunity. So obviously, he'll be better able to handle the virus because of a double exposure or triple exposure compared to you.
Sure.
But both of y'all are likely to be protected in terms of life as well as in terms of severe disease.
Thank you, sir. Thank you.
Sure. Niranjan.
Yes, sir. Supe, sir, can you please on your camera?
Yes, sure. I have a very small question to Shashank. Shashank, you passingly said that if I get a chance, I'll take one more vaccine after 6 months or something like that. So if I feel in next 3-4 months, if the vaccines are freely available, do you suggest that we should take one more vaccine? We have taken 2 Covishield doses in month of January and February.
Absolutely, sir. We have all gone through the same phase. We all took it on the 16th and then we took the next dose.
Yeah, exactly. We have all gone through that.
And now almost 6 months have passed.
Exactly. So because flu shots we used to take every yearly or 6 monthly, right? So we can now.
I think it's because we are still exposed.
Okay.
So I think the exposed environment, particularly working in COVID wards, we will need that. And that's the only thing is right now we don't have vaccine.
Sure. Okay.
But if and when it is available, absolutely yes. I would not think twice.
Sure.
Question important I wanted to ask Shashank is that, Shashank, there's a new paper from Birmingham where they said that elective surgery after the COVID infection, within 7 weeks you do elective surgery, there's a higher mortality risk. So maybe the gap would be what? After elective and after vaccine, because vaccine may elicit some kind of immunological response. So would there be a higher incidence of elective surgery complications following a vaccine and following COVID?
So with a killed vaccine, nothing will happen. Like say Covaxin, With Covishield, you can get, rarely minuscule percentage of blood clots or inflammatory response, or even neurological response like Guillain-Barré. So usually after a vaccine, do it after a month. Usually after COVID, do it after 2 or 3 months. Because there is something, see, COVID timetable is 2 to 3 weeks, normal acute COVID. And post-COVID timetable is 3 months. And in those 3 months, there is active inflammation, which is chronic. So you have a long COVID syndrome and you have a immune response which is happening. But if the surgery is absolutely semi-elective, sometimes the surgeries are elective, semi-elective and elective. So elective surgery, maybe 3 months is the best. A month and a half is reasonable with some risk. Okay, that's how I would put it very simply. If it is emergency, you can take it during COVID also, acute COVID also. There is no question asked. So we have to grade it because you can get two problems. What can happen in the post-COVID phase? As surgeons, you should know two things can happen. It is a thromboinflammatory disease. So there is a higher incidence of clots, strokes, infarcts, and clots like DVT. That's number one. So thrombo. And secondly, inflammatory events. You can get unusual, unknown inflammatory events. The longer you will go away from COVID, the lesser is the likelihood. And which is why that data has been published from United Kingdom. I hope I'm clear.
Thanks.
Sir, amazing the way you have explained about the longer you go away from COVID, the better chances you are to be surviving much more better as compared to the issues which are there. So there are many questions, but I will have to take 2-3 questions. Please, sir, don't go away. This is Dr. Vinita Singh from Patna. And she says, if a person gets COVID infection and the person is properly vaccinated, why is there a need of use of mask for him?
So if the person gets COVID and is vaccinated.
Yes, sir.
So during active COVID, inside the ward, you are saying, is that your question? Or so see, mask, see, there are new variants. So, mask will still allow you transmission to the new variants. Like AY1 and AY2. We didn't know what it was. We read it only 2 weeks back, and we were all, now though we don't give names like India variant, Nepal variant, UK variant. Now we say, Kappa, Delta, Lambda, Kappa was in Mumbai and, Delta is in, Alpha Delta is in Delhi. So ma'am, I think masking is the strongest way to protect you from variants. See, the vaccine will not protect you from variants, but the mask will. So the reason masking has become popular is to still protect you from exposure from the variants. Because that's the only way, because if there's immune escape, for example, madam, if you have taken Covishield and you are still likely, and if you're getting a Delta plus ke saath you get an encounter, then it is better that you have a mask so that you don't get that variant of concern. I hope I'm clear about that.
Absolutely. You're given a fairly reasonable answer, sir. One more question from Southern India. Sri Lakshmi Pinna Manini. Please excuse me of the surname. Sir, after how many months of second dose vaccine, a booster may be required for the healthcare workers?
Nobody knows that. Okay, probably 6 months, probably 1 year. We don't know how long these vaccines will confer immunity. It's an unanswered question because COVID is only a year and a half old. The vaccine trials are only 6 months old. Long-term confirmation presumption is that they will last immunity for 9 months to 15 months. So Pfizer, which is the first company which started vaccinating in United States and United Kingdom, feel that a booster dose should be given between 6 to 9 months. That is their feeling. It is not yet become a recommendation. And I feel that probably in 6 months to 9 months, we may need a booster, but we need to generate data. So see, in absence of evidence, everything is conjecture. But I think the thinking is with all these variants of concerns lurking, it's important that we may need a booster. And whether it should be the same vaccine or another vaccine is another question. But eventually it will become like a flu shot, an annual flu shot, which will be multivalent. So, in that multivalent flu shot, there will be a little mixture of alpha, beta, delta, gamma, and you will have a polyvalent, COVID vaccine, which may come after 3 to 4 years. But again, I may be totally wrong, but this is how it may evolve as a science. Like, COVID, the flu virus also mutates much faster than the COVID virus. COVID is a very slow mutating virus. Flu is a much faster mutating virus. So every year for flu, we get a multivalent strains or polyvalent strain vaccines. So multi-strain vaccines come.
Sir, I think from an endocrinologist, you have become an infectious specialist and a great epidemiologist working with the government of Maharashtra and having direct liaison to the good offices of the Ministry of Health and Family Welfare. And really, sir, all your suggestions and inputs have gone a long way in improving the status of Maharashtra. What it was 3 months back and where we are standing today is phenomenal. And it is all because of efforts of Dr. Avinash Supe sir, Dr. Shashank Joshi sir, and the team members and the chairman, Dr. Oak, who have done a wonderful way of going through this. And obviously, Municipal Corporation of Greater Mumbai has also done an excellent job in the city of Mumbai, and so and the other states and the other cities and town. Sir, one last question, because this is related to pregnancy, and we as an obstetrician get many calls or an opinion. Like I have in Sion Hospital about 150 to 200 patients coming every day for antenatal care, and 14,000 deliveries occurring at the largest slum of Asia, that is Dharavi. So they are asking me whether I should go ahead and take that pregnancy shot, or should I take as per the recommendation of ICMR and WHO in the lactation period. But still, there are many of them who are having that thing lurking in their mind because their relatives have taken. Some of them have taken in USA, some of them have said in here. But then do we have to write an application? Do we need a letter to be given? And how can we save from us medico-legally?
So medico-legally, I don't have an answer. Okay. I can tell you that individual decisions are with individual discretions. Vaccination is voluntary, number one. Let me put it up from a medico-legal, because these are experimental emergency use authorization vaccines. So every person has a right to refuse a vaccine. That is the first thing. Second thing is, these are early generation vaccines, and the data on pregnancy has not been cleared by Government of India because data is not available in the space of pregnancy or lactation.
Absolutely.
Lactation they allowed. As far as pregnancy they have concerned, they probably want to generate the data. At a personal level, you need to look at the ways, pros and cons. I think the pros and cons are very clear cut, that I think one needs to get vaccinated. I don't see a challenge with that. But it is at the individual risk, which the individual has to undertake, not by you and me. So you have to clearly tell them that this is an experimental vaccine, which is of emergency use authorization. Probably it may benefit you. Okay. But we cannot guarantee you, because COVID is only a year and a half old, and the data generated on this is not sufficient in India on this vaccine for pregnancy. So Government of India has not yet recommended. It may recommend in the future. We don't know. So if you are transparent in your communication, it is up to you. Now, point is, a Dharavi-like population will not ask you so many things. A Googleized WhatsApp University patient, which is graduated and got a PhD from WhatsApp University in Google, will ask you the question and also put you in trouble. So obviously, you need to understand the nuances of both. And such a patient who has WhatsApp may go and take a Pfizer. That's their problem. But as far as the Dharavi patient is concerned, if there are multiple comorbidities in that pregnancy, or if you suspect that it's going to be a complex obstetric situation or an encounter of difficulties, and there is COVID, it is better to get a COVID vaccine on. Because remember, if somebody has hypertension, diabetes, PIH, eclampsia, preeclampsia, and gets COVID on board, the likelihood of death to that pregnant mother is high. So obviously there you have some logic to dictate your decision making. But if you feel that there is no comorbidity, it's a young person, absolutely no challenges at all, you may take that chance. So again, you can stratify and individualize the cases. So I'm just giving some clues. As I said, these are not recommendations. No one recommends it as far as Indian law is concerned. So You see that risk is individual. Vaccination is not mandatory. It is voluntary because all the vaccines in India are emergency use authorization, early generation and experimental. But vaccine is the answer to COVID to at least save lives and save you from severe disease. But you may get a breakthrough of a mild or asymptomatic infection.
Sir, this question was asked by Dr. Sanjanwala. He is a very senior practitioner, and I also told him the same thing. But the way you have explained it so nicely that it has to be at the discretion of the patient, the doctor and the patient communication has to be very transparent, and you are just going to advise her, but the choice is hers, and that is what we are here. And please explain that the problems which can be there is of so many fetal and maternal outcome depending upon what comorbid condition she has. So today, on
Sir,
a-
Niranjan,
Yes, sir.
yes, you put up my question. My question is, Shashank, is there any harm to the mother or the baby born reported when the vaccine is taken in second or third trimester for whatever reason? Either they have taken because of high risk, whatever you said, the indications probably, or they have taken by way of fear or whatever their doctor agreed to give them. Is there anything reported out of this vaccination done in pregnancy and their outcome of the baby? There anything related to this vaccine, whether it has created some issue? Because the whole, as I agree with you that it is going to take a hell of a time to get the official approval for vaccine in the pregnancy.
So there is such an emergency use authorization in pregnancy in the US on the Pfizer vaccine because they have done some data generation. And I think the Ministry of Family Welfare and Health, where CDSCO is and DCGI is, they are also doing similar studies with Covaxin and Covishield. And in times to come, we will get that data. Pending that data, I think we should be transparent that we don't have that data. So there is a risk. See, the point is there will always be a risk. Even for normal pregnancy, there is a risk of malformation and fetal anomalies up to 2%. Correct me if I'm wrong, Niranjan. And if that risk will only get amplified with every added factor or comorbidity. So there is, see, when you cross the road also, there's always a theoretical risk that you may be hit by a car and you may die because of an accident. So that way, if you go, you will always have that risk, Dr. Saab. But you are right that in India, we have not done the data generation. And that is an unanswered question. Outside of India, in different geographies in Europe and US, such data is available. And there have been approvals from some platforms of some vaccines. But there have also been concerns. For example, on the mRNA platform, would that impact the biogenesis? We don't know. Embryogenesis, we don't know. Dr. Pai has done a lot of work in embryology from United States. So, you know, if he asked me that question, I would not know answers to it. So we have data with conflicting reports. It's an emerging science. We are not even 2 years into COVID. And therefore, to expect a approval for pregnancy is a little out of proportion. We have to save the mother's life. That's our first objective. So if the mother is likely to die due to a COVID and she's in a comorbid category where there is likelihood of a COVID death because of a lack of vaccination, then your justification is stronger. In absence of that, you have to look at the vaccines available. So you have Sputnik available, you have Covishield available, platforms which can cause minuscule clots because they're adenovectoral platforms, may cause thrombotic episodes or unusual inflammatory reactions or immunological reactions, which in pregnancy are unlikely to happen because, you know, pregnancy is a state flushed with steroids, while Covaxin is a killed space. So likelihood of its impact is going to be a little better. So these are the things which we need to discuss and talk. But as I said, you know, I am talking more of theory here without data or evidence. And today we are in the era of evidence-based medicine. In fact, you will get a lot of evidence which will happen by accident. For example, you will get enough people now who are vaccinated who will get pregnant on these vaccines, where you will know what are the outcomes, which are fetal outcomes and otherwise. Also, I am reasonably certain that enough pregnant women in India, at least a good 500 or 1,000 must have got vaccinated by now. Okay. we need to do systematic evaluation of them for both their maternal and fetal outcomes. But till that data is not generated, whatever I say is completely anecdotal and cannot be used as science at all.
Amazing, sir. Sir, this can go on for 1 hour, but I can see Dr. Rishikesh Pai, sir, is waiting eagerly. Sir, we have crossed more than 3,000 viewers and there are still questions coming. But sir, I need you next time for sure with your valuable presence. And of course, you will agree to that in the near future. Hope we do not get the third wave. As you say, if you continue the SMS, and if in case we get it, we should be carefully getting out of that with practicing all the guidelines, more vaccination being done, and herd immunity is the only answer. And you have rightly predicted. I know you are not a crystal ball gazer, but obviously we can come out of this period by next April 2022. And I wish you a great time, sir. And we will catch up with you soon. Thank you so much for being with us. Well, now we move on to the next trending and the hot topic, and that is AI. We see AI in our day-to-day life. Google has gone ahead. You have Siri, you have Alexa, you have automated homes where you just say, or you just snap your fingers and the light is on. What type of color of light you want, whether you want something cold drink from your fridge, you just have to ask for it. And you have Google Next. It can play you news. But then artificial intelligence has gone a long way, not only in technology, but it has gone a long way in reproductive medicine. And today we have the only guy who is a pioneer in IVF, and he has a lot of successful pregnancies of celebrities and has got centers all over India. He has also done MSc and Masters in embryology from United States of America. And he has got a lot of research. He's going to give that wonderful insight to all of you and to all of us about artificial intelligence use in reproductive medicine for the gynecologist of 2021. So I welcome Dr. Rishikesh Pai. The forum is yours. Welcome, sir.
Thank you, Niranjan. I'll just share my talk. First, let me just... Can you see the screen?
Yes, sir.
Okay. So basically, I'm going to talk to you today about a new emerging area of precision medicine and AI in ART, and of course in reproductive medicine. So what is artificial intelligence? Artificial intelligence is intelligence demonstrated by machines that mimic cognitive function that humans associate with the human mind, such as learning and problem solving. Machine with AI does not possess the natural intelligence displayed by humans and animals, which involves consciousness and emotions. So human intelligence, if you put it in mathematical terms, is equal to general intelligence, which is standard AI, which we know in machine learning, that is cognitive learning and problem solving, plus biological intelligence, which is consciousness and emotion. We need to improve this general intelligence, but we need to see that the machines don't develop biological intelligence and take over the human being. So the problem is, if we can enhance general intelligence without touching biological intelligence, then we will be able to achieve a lot. So what are the applications of artificial general intelligence? One is automated reasoning. Computers can reason completely or nearly completely in an automatic fashion. Second is knowledge representation. You can diagnose a medical condition or having a dialogue in a natural language. Automated planning, that is autonomous robots, unmanned vehicles. Machine ability, you can move and manipulate objects using machines. Then you have natural language processing, computers capable of understanding the contents of documents, including the contextual nuances of language within them. We have machine perception. It is the capability of a computer system to interpret data in a manner that is similar to the way humans use their senses in to relate to the world around them, like vision, touch, smell, hearing. And then we have machine learning, which is the study of computer algorithms that improve automatically through experience. The machine improves itself on its own as it goes along. So what is machine learning? Machine learning is a form of AI in which a machine can learn and adapt to situations and data training. Typically, a training data set is used to train a computer program to connect objects such as images that are described using a series of features like color, shape, and texture with specific labels of classes. For example, cancer or non-cancer. You can see a skin lesion, and by looking at it, the machine can say, okay, this is a cancer or this is a non-cancer. Machine learning encompasses two main approaches: supervised and unsupervised learning. In supervised learning, the classes or labels are known during training. And in contrast, unsupervised learning, such as hierarchical clustering, is used to discover structure within data, such as the existence of classes. For example, if you look at this, I'll go to it later. So, but when you're doing this machine learning, you need a lot of speed, memory, energy consumption is massive. So instead of that, you have started doing cloud computing. As you can see here, there are a lot of other easier programs that are available, and all this has made machine learning quite easy to achieve. So what are the techniques of machine learning? There are several techniques like logistic regression, random forest, Naive-based classifier, support vector machine. But the commonly is for image analysis, we use what is known as artificial neural networks, which include the recently developed deep neural networks. So what is an artificial neural network? Artificial neural networks are machine learning techniques that mimic aspects of how brains work. A neural network typically consists of several layers of artificial neurons fully connected to each other by edges, each one associated with a weight. Each neuron receives signals from multiple neurons in the previous layer, integrates these signals, and fires if the integrated signals are above a specific threshold. So you have multiple. These are not actual network. It is all in a like a digital space. For example, one of the types of artificial network is the deep or convoluted neural network, which is an extended neural network by increasing the number of layers and the number of neurons per layer. So more layers are there in the deep neural network, and deep neural networks can be trained to classify complex objects, for example, images or videos. So when you are using machine learning to analyze images or videos, you need a deep neural network. So if you look at the convoluted neural networks, they are very powerful for image classification and object detection. Thus, they are widely used in biomedical imaging domain. And then we also have got what is known as free to open source. That is, you don't have to pay for them. Like TensorFlow is there, which is on a Google platform. We have got PyTorch, which is on a Facebook AI Research Lab platform. So look at this photograph. So normally computer will, suppose this is an elephant, the computer will have, this is known as supervised network. Computer will be shown this photo and it says, this you look at this photo, you know that it's an elephant. But inside the computer will have a machine learning section where the machine will start analyzing multiple things in this elephant, the color of the skin, the grayscale areas, the contours. Like this, they can analyze as much as 40,000 various variables, which you cannot see with your naked eye. And this also is inputted by the machine. And these variables will also be considered when the machine comes to the conclusion that this photograph is of an elephant. And that is known as unsupervised learning. And this is what is artificial. So the computer itself trains itself through these deep neural networks. It keeps on training itself and refining itself so that it can quickly tell you that this is the elephant or this is a penguin, etc., etc. And that is where, when the computer trains itself, that is a fear that in this evolution of the computer, as it trains itself, it will also evolve into biological intelligence, and it will start behaving like a human being with emotions and consciousness. So this is the danger area which many people are worried about. So what are the benefits of AI? Economic benefits. It can improve healthcare, making diagnosis more precise, enabling better prevention of disease, increase the efficiency of farming, contribute to climate change mitigation and adaptation, improve the efficacy and efficiency of production systems through predictive maintenance. Then high profile examples, as Niranjan told us, autonomous vehicles such as drones and self-driving cars, creative art, machines can write poetry, proving mathematical theorems, playing games such as chess, search engines such as Google search, online assistants such as Siri, image recognition in photographs. You can have a face, anywhere. Someone was telling me that there's a new technology that the camera can see your face and you can pick up the person. You can pick up a criminal among thousands of faces, spam filtering, predicting flight delays, prediction of judicial decisions, targeting online advertisement, energy storage, answering service, robotic service devices, extensive use in social media. You can have chatbots. So many times you should be chatting with a beautiful woman or a very handsome man, but actually it may be a machine chatting with you, robotic friends, and you can post stories as such. So what are the other things that it can do? So if you look at the artificial intelligence in medicine, it can detect genetic variants from large-scale genomic data sets and infer the functional impact of germline and somatic genetic variant. You can predict responses to therapy based on genomic features. Leveraging medical imaging, this is what we are interested in reproductive medicine, that how can we use image? So there is a big database. It is called ImageNet. It has got 14 million images and it is a free source. Many people access this ImageNet data when they are creating their own machine learning system. You can use it for skin lesions to decide whether it is a malignant or a non-malignant skin lesion. You can use retinal scans. You can predict diabetic retinopathy by looking at the retinal scan. The machine can predict it. So what are the things that it can do? Other things in medicine, you can analyze pathological tissues. For example, you want to know now presently, there's a famous person in Tata Cancer. I'll not take the name, but every time we want to differentiate between cancer, whether this is a cancer or non-cancer, we take the slide and she tells us whether that's cancer or not. She is the last one. But ultimately, slowly, by taking this photograph, the machine will tell you whether that's a cancer or non-cancer. Prediction whether tumors have certain genetic alterations. Diagnose disease from radiology. You will be surprised that one of my friends, he was in the central government, and few years back they had gone to Israel, and there are systems in Israel where the whole diagnosis of CT MRI can be done by machine. No human is necessary for that diagnosis. Identifying polyps on colonoscopic videos. And artificial intelligence can also be applied to medical records from thousands of patients from several centers, and it has shown to reliably predict the risk of readmission. For example, if you have COVID patients, you may be able to predict who will get a long COVID or a short COVID. This is going to happen through AI. So what about reproductive medicine? So now we have discussed what is AI, what is machine learning, what is deep convoluted neural networks. We have discussed what is the application in medicine. Now let us come to my area of specialty, and that is reproductive medicine. So what can AI be used for in reproductive medicine? So one of the things that is the most important thing, and one of the things that what Dr. Shashank said, and the biggest thing what is the main problem in India? We don't have the data. We don't have data connected. So the dream will be for 1.3 billion people anywhere in the country, they go for a medical problem, they have to be treated and the data entry has to be done. Once the data entry is done, then we'll be able to generate data and we'll be able to know how many people received the vaccine, what was the response, what were the children, was there any malformations in the children which were born following the vaccination. All that is not possible at present in India because our EMR, the data system is very weak, especially in the private area. In fact, you'll be surprised that in the government hospitals, the government has slowly and steadily started putting data into place. But unfortunately, in the private scenario where each one of us has got small private nursing homes, we have not been able to do proper data collection and data entry. We don't have the habit of entering data when we are treating patients, and that is going to be a setback. And as we go along, we will all have to buy EMRs, and we'll ultimately, my vision is that the National Medical Council at certain point in time will tell everyone that if you want to run a nursing home, you have to have a standard data system and you have to enter the data before you treat the patient. So if you look at the reproductive medicine application, minimizing patient stress and increasing clinical efficiency. There's a doctor in United States recently. I was attending one of the webinars just about a month back. And what he did was he was telling us that in his lab of IVF, there are on a particular day, there may be 9 patients who are for ovum pickup, while on other days, there is no patient. So what happens in that day when there are 9 patients, there's a huge load on the IVF lab, and their performance may go down. So he used the artificial intelligence to distribute the work such that every day there were in the same number of patients for ovum pickup. So he could, using AI, improve the work efficiency in the clinic and lab. You can use it for stock taking, inventory, quality control, quality assurance, data analysis, research, and publication. So what about the male factor? Where can we use it in male factor? You can use artificial intelligence to predict male factor infertility, predict the likelihood of sperm extraction in the azoospermic patient, use data mining methods to determine the impact of lifestyle and environmental factors on seminal quality and fertility rates in men has also been explored. And you can also use smartphone-based applications for semen analysis as well as sperm viability and DNA integrity. You can also use artificial intelligence to evaluate sperm morphology and DNA integrity, as well as sperm. Use it for selecting good quality sperm when you're doing IVF or ICSI. You can identify sperm cells. You know, many times we have these non-obstructive azoospermia patients, and we do testicular biopsy and we search for sperm. So, you know, it takes about 4-5 hours. Many of the time, embryologists are sitting, and one by one, each field is checked for a sperm, which may be one in hundreds and thousands of cells. You may get a one small sperm. You can use machine now, machine learning. Machine can pick up which is the sperm, and you can direct the embryologist to say, okay, look, there in that particular field at 6 o'clock level, there is that sperm, and it can identify that sperm. It can help the embryologist to pick up the sperm. Not only that, you can have AI-assisted sperm selection system. So when we are doing ICSI, this is known as SID. This is we do a lot of artificial intelligence in our lab for embryo assessment. But the same company with which we have collaborated with for our ERICA system, which I'll show you, the same company has evolved a SID system. So what is SID? What it does is that as you are doing the ICSI micromanipulation, as you can doing it, they connect this screen to the internet and to their server in Mexico, and the SID tells us what is the best sperm to pick up and inject to get the best embryo quality and best fertilization. So the machine will grade the sperm as it is moving and analyze its shape and all that, and pick up. We can direct you to pick up the right sperm and give the best possible chance of pregnancy. You can also do machine learning in oocyte. So in oocyte, we can do oocyte imaging using machine learning prior to ICSI, and you can identify, you know, these non-invasive markers. You may think that there are only 3, but there may be as many as 40,000 markers which the machine is analyzing through its high-level convoluted and deep neural networks, which your human eye cannot analyze. For example, this system is there, and my friend from Canada, Navot, has evolved this system, which we are about to install in our lab. So once we do the pickup and dissect the oocyte prior to microinjection, you can analyze the oocyte. And this picture of this oocyte is exported to the servers in Canada. And the Canadian server tells you that this oocyte, after you freeze this oocyte and thaw it after 10 years, when this patient has come for oocyte freezing, fertility preservation, she wants to freeze her oocyte at the age of 30, and she wants to have a child at the age of 40. So when I take out this oocyte, and there are 8 of them, I can analyze the oocyte, and the machine will say, okay, this oocyte has got only 33% chance of becoming an embryo after you thaw it and micro-inject it, while this oocyte has got a 53% chance of becoming an embryo. So if suppose on the first attempt, I take out 8 oocytes and only 3 have a good chance, I can counsel the patient and say, listen, you have got 8 oocytes, but only 3 are good enough to give a good pregnancy chance in the future. So maybe you should go for one more cycle of oocyte freezing. So the machine learning can grade the oocyte and predict what oocyte will go for a pregnancy. Machine can also grade the embryos. So using images, you can analyze the embryos, and you can tell the embryo whether this embryo is a good. So they do the different workers and researchers in the last 2 years have done different. One has used what is known as class activating mapping method, which generates heat maps and images. So different technologies have been used. Another has been using what is known as exception architecture analysis and a novel. So in our lab, we also use what is known as ERICA system. So I would like to show you the ERICA system. So this is the ERICA system. So when we have got, let's say on on day 5, we have got 5 blastocysts. We want to grade the blastocysts. We take the images of these blastocysts and we export the image to the server in Mexico, and the Mexico server grades the images and grades. Okay, they will say this is the best blastocyst you can use for transfer and get the highest chance of pregnancy. It will be genetically abnormal child and has a very low miscarriage rate. So using image analysis and video analysis, you can not only use the sperm, the oocyte, or the embryos using AI learning to predict good chance and outcome of pregnancy. So you can say that you can also use artificial intelligence to predict genetic analysis. So normally in analyzing genetic competence of the embryo, you normally do what is known as embryo biopsy and analysis, which is known as PGTA, which we do in our lab. But now as we go along, we'll be able to correlate the genetic analysis of the embryo with actual visual analysis. And the machine will slowly learn. And what time will come when we'll not be able to, we don't have to biopsy the embryo. Using the image analysis, you will be able to say, okay, this embryo is genetically normal or this embryo is genetically abnormal. So you can use a non-invasive technology to analyze the embryo. Similarly, at present, we are using genetic analysis, but using machine learning. This is a study that was done by New York Langone Fertility Center. You can use machine learning to analyze the genetic report and give a better prediction of a particular embryo. What about transfer? So you can use what is known as ultrasound inputs. You can use ultrasound analysis of the lining. You can find out what is the thickness of the lining, the appearance of the lining, what is the blood flow, and the machine can correlate these images and tell you exactly whether this lining is ideal for transfer or not. If that lining is not ideal, you can freeze the embryos in that cycle and transfer in the next cycle. They will tell you when to transfer to give the best chance of pregnancy. All that is going to be possible using machine learning. So what are the other tools that it can use? So you can see here, there are a lot of the papers that have been done. And this is a paper that has come from different groups of individuals which has predicted. So what are the problems in artificial intelligence? Multiple platforms are being used. Different groups are using multiple platforms. There's a lack of standardization, data bias. So you may have a machine which will take only the good data and will give a wrong prediction. So you need to have a balance of good images and bad images. And recently there has been a new group from Singapore who has created a new program which can actually eliminate bad data. There's again ethnic diversity. For example, in COVID vaccination, they always say that Indian people may be different from Caucasian people. So similarly, in the machine learning data also, Indian data may be different from a Caucasian data. So for example, if you are basing our analysis on oocytes that are analyzed abroad, we may get a wrong data. So in fact, I have started with our group has started now doing data feeding, and we are creating our own data sets using machine learning so that we can have our own analysis of data. Again, this has to be from multiple pool data, which will give a better prediction. You can have replication across cohorts and prospective validation of a study, and it is a must. So this data sharing is important. Implementation and integration of information is important. And in borderline cases, there may be a collaboration between humans and AI. So what are the other disadvantages of AI? Algorithmic bias may be there. You can create deep fakes, fake news, spams, phishing fraud. Deep fakes have garnered widespread attention. There, many people are fearing that machine learning may, create in a lot of job loss. And there's a prediction that 9 to 40%, 47% job loss may be there in areas such as fast foods, cooks, while, healthcare is going to have a lot of jobs. So I think a lot of youngsters in the future should enter the healthcare. So in those areas where there's a human-to-human contact, those are the jobs that are going to remain in the future. While those areas where there is a lot of automation, machine learning is going to take over the future. So there is always a problem. As I told you, the big fear that everyone has got is that there is something called biological intelligence. So as the machines are trained to convoluted neural networks to evolve their programs, there is a fear that AI will spell the end to the human race. And that's what Stephen Hawking said. Once humans develop artificial intelligence, AI will take off on its own and redesign itself at an ever-increasing rate. Humans who are limited by slow biological evolution will be unable to compete and would be superseded. So, even a parallel thought process was is COVID designed by humans, and that is why it is mutating at an abnormally high pace. Normally, a virus doesn't mutate at such a high pace. Was it that it was a humanly designed virus, just like AI is a humanly designed system, and as it grows and rapidly grows, it may be overcome or overpower the human race. The opinions of experts within the field of artificial intelligence is mixed, with sizable fraction both concerned and unconcerned by risk from eventual superhumanly capable AI. For the danger of uncontrolled advanced AI to be realized, the hypothetical AI would have to overpower or outthink all of humanity, which some feel is a remote possibility. In fact, Facebook CEO Mark Zuckerberg believes AI will unlock a huge amount of positive things such as curing disease and increasing the safety of autonomous cars. Other counter arguments revolve around human being either intrinsically or convergently valuable from the perspective of an artificial intelligence. Oracle CEO Mark Hurd has stated that AI will actually create more jobs, not less jobs. So job problem is a big thing that people are worried about. And that's why a group of prominent tech titans, including Peter Thiel of PayPal, Jeff Bezos of Amazon, and Elon Musk of Tesla, have committed $1 billion to OpenAI, a non-profit company aimed at championing responsible artificial intelligence development. So over the last 3 to 5 years, we have witnessed the increasing utility and exciting applications of artificial intelligence in OBGYN, especially cancer, infections, and reproductive medicine. Artificial intelligence will usher in a new era of standardization, automation, and precision to IVF. Artificial intelligence-driven approaches are likely to be more objective, more rapid, and most importantly, more accurate. While applications of AI in embryology have gained the most attention and shown the greatest promise, it is likely its use will widen to other aspects of reproductive medicine. Wider use of AI in precisely assessing patient characteristics such as ovarian reserve, age, endocrine status, and clinical diagnostic tests will undoubtedly increase the efficacy and efficiency of diagnosis and treatments of all reproductive disorders. So I would like to conclude by saying that the future of mankind is in the atom. Computers is one of the main futures. Atom is there, the byte, as I told you, the computer, the gene, and sometimes I would also put in and add on after the COVID infection, the virus. I'd like to thank you all for a very patient hearing.
Thank you, Rishikesh, sir. The way you have gone through the history of AI and explained about CNN, the deep learning, how you do the machine learning, and what are the applications, not only in the field of genetics, but also for your day-to-day practice in the IVF lab, which you have been using now in India, and your friend in Canada who has done a wonderful job also. And obviously for the sperms, for their motility, and the amount of literature you have gone through is amazing. I don't know how you get so much time to read it and present to us, because this is the first time ever Dr. Rishikesh Pai sir has given a lecture on a trending topic. And he called me yesterday evening, Niranjan, I need to change the topic, and it is artificial intelligence in reproductive medicine. And we have got more than 3,000 viewers who are logged in to hear you, and the way you have explained us is amazing, sir. Sir, there are few questions which are there to be asked by the audience. As you are aware that artificial intelligence is a very, very new topic, and as a postgraduate student or as a postgraduate teacher, apart from the routine thesis which we take, like preterm labor, or we do a study on anemia or preeclampsia, how can we collaborate in India in such situations with, say, Bloom IVF, or probably with your friends abroad?
So basically, this is a very new field, and here I would say that a lot of the younger postgraduates can do a lot of work, because there are already a lot of engineers in India who are doing the feeding. So it's basically a data set. So you will have to, for example, so you want to do some analysis on preterm labor, and create a prediction model. You can create a prediction model. So you have to just give them the data inputs, and there are groups and groups of machine engineers now who will feed that data. For example, I am creating a machine learning data for our own group, where we will be taking the images of the oocyte, the sperms, and the the embryos and the endometrium and giving the feed. So that they need to have two types of feed, a positive feed and a negative feed. A positive feed is this went gave a good outcome. A negative feed is this combination gave a bad outcome. So the machine will start learning. Once you create the data set, then you have to involve a lot of other friend circle. So you can do a multi-centric trial. So once you do a basic data set, you can involve multiple centers and do a multi-centric trial, and then create a larger data set, and at that data set you can publish your report result, as well as you can do commercial entry and you can sell that data. This you can sell the program. So you have a server, so many units in the world can enter that data and they can get a prediction from it. So now the advantage of India is that this data, for example, when I do a oocyte analysis, I'm collaborating at present, the cost is $500 per patient. Now, once I get my data going, I can charge them 500 rupees also. So that is a power. The future of artificial intelligence is in India, because we will be able to dominate once we have the data analysis on host of things. Tomorrow a surgeon wants to do, I mean, skin, the whole skin is visual. Just imagine, you just take a photo and machine will tell you whether this is a ringworm or this is a rosier or whatever. You don't need at all. You don't need the skin specialist. You will say the skin specialist thinks and he tells you. He will ask you symptoms. So you just say, the machine will ask you, what is your symptom? Are you itching? What do you do? As soon as you tell the machine, the diagnosis will pop out. So imaging, wherever the eye sense is involved, future is very bleak for that people. Those people should change their profession because their future is bleak. So future image analysis, future is totally. So more and more people should go into surgical lines or medical lines, image analysis lines. Now, for example, radiology is very popular at present. That's not going to be popular anymore because machine will tell. So one doctor using 5 CT scans will be able to do everything. He has to just sign at the end of the thing. He will not need that many radiologists at all. So remember, this is an evolving field. And because my advice to younger generation is that you have to remember that you have to change yourself 4 times in your life, future life. You have to evolve. You have to keep on rediscovering yourself every 10 years. You can't stay, if suppose there's a laparoscopic surgeon and he keeps on doing laparoscopy, after some time, he will become defunct. There will be new technologies that will come in.
Absolutely great, sir. The way you have explained artificial intelligence.
One sec, Rishi. Niranjan, one question.
Yes, sir. Yes, sir.
Is
Welcome,
that,
sir.
Is that Niranjan, with all this artificial intelligence going in so much strong, the way he said, and the computer making the diagnosis, your artificial intelligence making the diagnosis, where will the medical legality of the responsibility from if there is any mistake?
The final signature has to be done by the doctor. No, I am just saying that instead of doctor, suppose there's a radiologist who is employing 10 radiologists, he'll be able to do employ less because the machine will do all the work for him. He has to sign. So when he signs, he takes the responsibility of that medical legal problem.
Okay. So that way, that shouldn't be the issue.
Yeah. So, but then what will happen? There's going to be a job loss. So you have to think like that there is going to be job, but there are new jobs that will evolve. So there's it's a ongoing. Unfortunately, our generation didn't have the instability which is being faced by the younger generation, because in younger generation the technology changes so fast that the younger generation will have to be on their toes all the time. We were lucky, Dr. Janjanwala sir, we were lucky. Our generation we enjoyed the technology, but the technology we enjoyed at a slower pace. The new generation will have to keep pace with the technology very rapidly.
Absolutely, absolutely. We are having experts, seniors, and also youngsters joining us, and they are really enjoying the live feed on Facebook, on YouTube, on Shield Connect, and obviously there are many been questions asked, but as rightly said by Dr. Rishikesh Pai, we need to have more data, and that data has to be embedded into the machine learning, and lo, you find out that one day, obviously it is going to assist you. It has already been doing in the field of radiography, radiology, ultrasound, MRI, and in various fields. But surely your lecture was a wonderful opening to all of us. I can suggest that IIT Mumbai is.
Excellent lecture, Rishi.
Thank you, sir. Thank you.
I can suggest one more thing. IIT Mumbai, they have a machine learning branch, plus they are having masters, but all these are done by the engineers, because this is the scope of engineers. So when doctors and engineers come together, it will really make a lot of difference. And that is what Dr. Rishikesh Pai has guided all of us, the younger generation, including me. I would love to focus on next 10 years, something on artificial intelligence, give it to Foxy, give it to MOGS, give it to our brothers and sisters, so they surely can be able to use in their day-to-day practice. It is not that they are going to replace, but what Dr. Rishikesh Pai said very appropriately, that the data which we have, India really is going to be the king. It is going to be the next game changer for artificial intelligence. What is your take on that, Rishikesh Pai?
Yeah, one advice I would like to tell all the juniors, because you have a lot of juniors who, or even doctors. See, many of us clinicians now, we need to now also go back to research, because when we were trained as students, we didn't have that research ability. We didn't have good practices. We were struggling with our practices. Now we are more settled, so we can go back to research. See, there are a lot of labs in our country which are doing basic. If you have TIFR, you have got IRR, so many of the labs are there. You have got huge amount of, now with the COVID infection, that what has happened is huge amount of sequencers have come into the country. So as the COVID infection abates, a lot of new technology has come into the country. So my advice is that you must start doing basic research. You can do, see, our Indian research is good. It's called observational research. ये इतना preterm birth हुआ, ऐसा हुआ, ये हुआ, वो हुआ. Now you need to do basic research. For that, you don't need to go abroad. You just need to collect the tissues and collaborate with let's say an engineer in IIT. You take the data set of images and you collaborate with the IIT engineer and start giving him the input. I told you now, the elephant photograph. He needs the elephant photograph and he needs the final outcome. Then he feeds it into his machine learning program and he evolves the data set. He evolves a system which then you can publish, and you can publish at the international level. Okay. So similarly, these things, multiple, you have got TIFR 100 and so many labs. You have got CRISPR. You know, there is main big CRISPR labs are happening all over the country. You can use those labs and collaborate with the various technologies using CRISPR. So what I'm saying is that my request to all the juniors is that they should not enter private practice too early. What is there in private practice? They should spend 5 to 10 years in the government institute, do research, and then at the end of it, when you get out, now you not only are respected, but as soon as you get out, you will get rapidly practice. See, in our country, practice is given more importance than other things. In the other countries, research is given. If you tell someone and say, I have done 40,000 hysterectomies, they will not bother with you. But if you tell them something that I have done a research and Cochrane review on so many things, they will really respect you. So and that is what we need to bring a change about in our country.
If you have
Our
artificial
priorities are not correct, according to me. Yes, we were in the evolutionary phase where we were struggling, and our basic thing was to start nursing home, service patient. Now we have come to the next phase, and that's a changing India. So now we must change our practice and our approach to life as well.
Rishi, the way things are going, you expect an artificial intelligence ministry? If such a ministry is created, then I would expect you to be the first minister in the center for the artificial intelligence ministry.
Sir, you know what I'm saying is that, you know, I like to always talk when I do it. So I've already got artificial intelligence analysis of the embryo. I'm in the process. Today only I have imported the new camera for the image analysis of the oocyte. So I am into it. So we have to be into it and do it.
Wonderful. Thank you, Dr. Rishikesh Pai. Dr. Rishikesh Pai is the director of Bloom IVF. There are 12 centers all over India, mainly in the Dadar, in Kemps Corner, in Mumbai, at Leelavati, Chandigarh, Delhi. Any one of you can be easily contacting sir. Sir is quite available on his phone and he is there to guide us. So it was a wonderful session and we just
Thank you.
covered trending topics, and the amount of energy, enthusiasm which both of our speakers have given is amazing. And obviously we had a surprise visitor and a guest on board, and that was Dr. Sanjanwala, a very senior practitioner, honorary professor at the Dr. R.N. Cooper Hospital for practicing more than 45 years now. Thank you so much, sir, for being there. Without much ado, I would like now to hand over the mic to Dr. Prachi from Shield Connect to give the vote of thanks. And we will catch up with you soon on 7th of July with two wonderful speakers. Adieu.
Thank you, sir. Thank you very much. Thank you for your excellent support and the moderation. Thank you, Chavan, sir. Thank you, Dr. Shashank Joshi, sir, and Dr. Rishikesh Pai, sir, for the excellent talks on trending and on the hot topics. Thank you, Dr. Avinash Supe, sir, and Dr. Madhuri Patel, ma'am, for accepting our invitation and spending time with us and taking time out from your busy schedule. And last but not the least, of course, thank you very much, all our participants and viewers for attending this beautiful session. So thank you very much. And thank you, Chavan, sir. Yes.
Thank you.
Thank you, Dr. Prachi. Thank you so much.
Thank you, sir.
Are we offline now?
Yes, sir, we can be offline.
No, we are still live. We are still on air. Chitra?